Hello, everyone, and welcome. I'm Dr. Hello, everyone, and welcome. I'm Dr. David Rubin from the University. Hello, everyone, and welcome. I'm Dr. David Rubin from the University of Chicago. Thank you for joining us for this special CME event. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for this educational activity, which is titled Ulcerative Colitis in the 21st Century, Incorporating Guidelines and Real-World Evidence in Practice to Enhance Patient-Centered Care. Tonight's activity is brought to you by CME Outfitters, our award-winning accredited provider of continuing education for clinicians like you worldwide. Today's CME and CE activity is also eligible for the ABIM mock points. Make sure you participate in the program and complete the post-test and evaluation. I want to point out to you that you can also do the MIPS improvement activity, and you can follow some of the instructions here as well as on the website. So again, I'm David Rubin. I'm a professor of medicine at the University of Chicago. I'm also the chief of our GI division there. And you can follow me as well, and my Twitter handle is IBDMD. I'd like to welcome our panel joining me today. First, let me introduce my good friend, Miguel Reguero. Dr. Reguero is professor and chair of the Department of Gastroenterology, Hepatology, and Nutrition, and the Pierre C. and Renee A. Bora Family Endowed Chair in Gastroenterology and Hepatology at the Cleveland Clinic in Cleveland, Ohio. You can also follow Dr. Reguero on his Twitter handle, which is at mregueromd. Welcome, Miguel. Thanks for being with us.
Thank you, David. Good to be here.
Your audio sounds perfect. And next, let me introduce my other good friend, Sushila Dalal. Dr. Dalal is an assistant professor of medicine at the University of Chicago and works with me and one of my partners, and I'm really excited that she is with us. She's just an outstanding educator, as you're all going to hear in a minute. You can follow Dr. Dalal on Twitter at Sushila Dalal. She's got a great Twitter handle. Welcome, Sushila. Thanks for being with us.
Thanks so much.
Before we begin our main program, I wanted to talk a bit about COVID-19, the pandemic, and how it's affecting some of our patients. Obviously, that's one of the reasons why we're doing this virtually and why we're not all together in our hometown here in Chicago doing this live. So let's talk a little bit more about what's going on with COVID-19, and we're going to actually incorporate a CME type question as part of this. So first of all, remember that there are hundreds of different coronaviruses, and most of them circulate among animals, and some of them jump from animals to humans. There have been a couple epidemics previously described, like the original severe acute respiratory syndrome, or SARS, of 2002, and subsequently the Middle Eastern respiratory syndrome of 2012. These were both caused by coronaviruses as well. In December, as we've all heard many times now, a novel coronavirus, which has been subsequently named SARS-CoV-2, was discovered in China and subsequently has become the pandemic. It causes a disease that has been named COVID-19, which stands for coronavirus disease. 19 means 2019. As we understand it now, the incubation time is a median of 5 days with a range of between 2 and 11.5 days. And the clinical presentation is most commonly respiratory with infectious phase and then an inflammatory phase. The infectious phase is often characterized by fever and cough and congestion, but also obviously has characteristic chest abnormalities, bilateral pneumonia, and lab abnormalities, lymphopenia. There are also up to, depending on whose cohort you look at, 50% of patients who may have GI symptoms that include anorexia, diarrhea, vomiting, or abdominal pain. And also, depending on whose cohort you look at, these may precede or lag behind respiratory symptoms. One thing to keep in mind is just a pearl about this is that most people who develop the GI symptoms associated with this will also have the more systemic and respiratory symptoms as well. So as far as we know, it's not a common event at all to just have GI symptoms as the only manifestation of this particular virus. But we have learned that the virus has a point of entry through receptors that are expressed not only in the respiratory tract, but also in the GI tract. So we're going to look at a video which the CME Outfitter crew put together. And so you can remember, there's actually 29 different proteins that are involved in what we call coronavirus. The spike proteins on the surface is what people have targeted as potentially the way to develop vaccinations. And the N protein in the middle there is the nucleocapsid protein. And of course, you see the RNA, which is the main machinery of how this virus replicates. The AGA has developed a clinical practice update with a number of folks, myself included. And right now in the IBD space, we've been recommending that patients with IBD should continue their IBD therapies, and it's been emphasized the importance of staying in remission. This also includes continuing infusions at infusion centers that have safety protocols in place, including screening the patients as they arrive, space between chairs, etc. So far as we understand it, having IBD itself, whether it's Crohn's or colitis, does not appear to increase the risk of contracting SARS-CoV-2 or the subsequent development of COVID-19. There's an international registry called COVID IBD, actually Secure IBD, and it's at covidibd.org, which is publicly available if you want to see. There are now 877 cases of IBD patients who had confirmed COVID with their outcomes reported that are all available for you to see, and about 3% mortality, or 30 patients who have been reported to die associated with COVID who also had IBD. So far, there's not been a spike of any specific therapies of interest except steroids, which are associated with worse outcomes in this infection, as they are with so many other things. In addition, there have been some instructions that have come out, admittedly with very limited data, but when patients develop COVID-19, especially when they're in that infectious phase, the first phase of the condition, to hold immune modulating therapies, including biologics, at least until the condition passes. There's great interest in whether our anti-cytokine therapies may actually be treatments for COVID-19 and reduce the systemic inflammatory phase of the disease. And there are actual trials going on in non-IBD populations to look at this, but that is not yet known well enough to say that our patients with IBD should stay on their therapies when they're first infected. So there's a lot we don't know. And of course, the half-lives of these therapies hang around longer anyway. So stay tuned. And if you do have a case of a patient with IBD who develops confirmed COVID-19 and you know the outcome, I really do encourage you to put it in this registry so that we can all learn from each other. This is a case. Monica is a 42-year-old woman with a 3-year history of ulcerative colitis. She is on anti-TNF therapy, and she is currently presenting with 4 bowel movements per day and seeing blood in most of them. She also has a fever of 39 degrees and a dry cough. You suspect that she might have the SARS-CoV-2 infection and developed COVID-19, plus or minus active IBD. Her CRP is 6. She's tested for Clostridioides difficile, which is negative, but on the nasopharyngeal PCR test, it's positive for the virus SARS-CoV-2. Okay, there we go. So we're going to test our system here, guys. See if you can answer this question related to Monica. How would you approach her treatment? Okay, we'll come back to that and we'll see what everyone said and what we would do as a group. So the clinical practice update that the AGA helped us put together describes how to approach patients with active IBD, as well as how to incorporate the management or at least considerations for the patient who has COVID-19, as we've seen with this patient example. So if the patient has symptoms or findings suggestive of COVID-19 and they test positive for COVID-2, the SARS-CoV-2, as this patient did, the recommendation is if they're on prednisone, try to get them down or off. And if you need to, switch to budesonide MMX. If they're already on 5-ASA or budesonide or other rectal topical therapies or nutritional treatments, you can continue those. The recommendations are currently to hold immunomodulator therapies, including our small molecule JAK inhibitor, and to delay additional dosing of biologics until the patient recovers from COVID-19, and at least in theory, and what we're interested in learning more about is when patients develop the IgG phase of antibodies, presuming that those may represent resolution of the infection and hopefully at least some degree of immunity. Obviously, in patients who are severely ill and in ICUs, the management of the COVID-19 takes precedence over anything with the IBD, and they may even be enrolled in clinical trials now for some of those treatments. So this is our general recommendation. If the patient had tested negative and you were still strongly considering whether this was COVID-19 and other evaluations for workup were negative, you still should treat them as though they may have COVID-19. Remember that the nasopharyngeal swabs have a sensitivity of only 70%, which means there can be false negatives in some of those situations. And then, of course, evaluate your patient to find out why she may have been having active IBD and what else might be going on, including whether or not she's having too much clearance of her anti-TNF therapy. So hopefully that gives you some guidance. There's a nice algorithm that describes the rest of this in that GastroPub, which is also available at the AGA website. So now that I told you all this, in this patient who has active colitis and who has a positive SARS-CoV-2 test with a fever and a cough, if we go back to the audience response questions, you get a second chance at it. You can try answering again. Same question, how would you approach the treatment? All right, so let's see how this went. Very good. So what I'm seeing here is the pre is blue and post is green. And you can see there's been a definite shift of folks. Some folks had said, stop all treatment. That had been almost half of you initially. And then after we talked a little bit about it and how you might use budesonide as a reasonable option for someone with active IBD, we got more than half of you to switch over. So that seems like the right thing to do. Remembering that she seems to have active colitis in this setting. You could certainly think that the SARS-CoV-2 might be contributing to her GI symptoms, or that it might even trigger her colitis, although we don't know if that's actually happening yet. But in any event, giving her the budesonide seems like a reasonable thing to do while we're trying to address her COVID-19 status and watch her evolve and hopefully recover from that. Very nice job. And we can come back to that during the Q&A if there are more questions. Thanks for that. Okay, so our first learning objective, and each of my faculty and I will be covering one learning objective, is to follow the updated ulcerative colitis guidelines to incorporate elements of prognosis into your diagnosis and treatment decision making. Let's go to another case. This is Ross. He's 70 years old, although he is quite well otherwise, and he has new symptoms. In the past month, he's had a mild weight loss of 6 pounds. He's had frequency of stools up to 5 a day, and he's seeing blood in about half of them, and he's also experiencing urgency. He's been a pretty healthy person. He runs every day, and obviously when he goes out for runs now, he can't make it because of his urgency. And he's still working as a consultant and is traveling occasionally. Baseline labs show that his hemoglobin is slightly low, his CRP is elevated, his Calprotectin is elevated, C. diff is negative, and here's a new thing that we're considering in these situations, of course. He was tested for SARS-CoV-2 by PCR nasopharyngeal swab. That's also negative. And you perform a colonoscopy and confirm ulcerative colitis and give him a Mayo endoscopic score of 2. Remember that the Mayo endoscopic score in ulcerative colitis goes from 0 to 3, 0 being normal and 3 being severe. So in these lab findings in this colonoscopy, I ask you to characterize Ross's disease activity. So in the last year or so, there have been a couple updates to the guidelines. The ACG came out with their clinical guideline for ulcerative colitis in April of 2019, and the AGA came out with a couple different guidelines, one related to mild to moderate disease, and the other, which is listed here, moderate to severe ulcerative colitis. You can see both of these guidelines went through a pretty rigorous society-based pathway in order to get approval and to be available for us to learn from. We'll cover some of the main takeaways from these guidelines in this presentation. So in the ACG guideline, there are a couple updates that are important to keep in mind. The first thing is that they differentiated activity from severity. Activity is how sick your patient is right now. Severity is prognosis. In addition, we developed a new disease activity index, which is based on how sick the patient is now, and separately called out prognosis or severity, which I'll show you in a moment. We also lumped moderately to severely active disease together in one category compared to mild disease, because in clinical practice, that's usually how people think of things, but also also because when you look at available therapies, which Miguel will be covering, you'll appreciate that the labels for many of our therapies are divided that way as well, and that's usually how we consider management. We included in the guidelines treatment of hospitalized patients, an update on colorectal cancer prevention and surveillance. And if you go to the main manuscript, you can just look at the executive summary, which are tables 2 and 3, which include 48 graded recommendations, which grades the level of evidence, and 54 key concept statements, which didn't amend themselves to recommendations and grading per se, or otherwise important statements. And if you spend a few minutes reading through all of those, you'll be completely updated on what the ACG guidelines said. The AGA guidelines are similar in some ways, and they had some minor differences, and also included Infliximab because that was approved by the FDA after the ACG guidelines came out. The AGA guidelines for moderate to severe colitis talk a little bit more about treatment naive and biologic naive patients, and they talk about what to do after TNF therapies don't work any longer, or if they don't work in the first place. And they also talked about using earlier biologics instead of stepping up, which the ACG guidelines admittedly did as well. And they also covered the hospitalized patient as the ACG did. So this is the ACG Activity Index. I just want to highlight a couple things that were new here. The first was for those who remember the previous True Love and Wits Modified Severity Index, which has been used for many years. Believe it or not, it didn't include remission. So that whole category is added to this activity index. It also did not include a measure of mucosal inflammation or ulcerations. So whether it's the Mayo endoscopic subscore, which is the second row from the bottom, or the ulcerative colitis endoscopic index of severity, or even fecal calprotectin, the new activity index does include these measures, recognizing the importance of knowing how inflamed the mucosa is in people with UC. You'll notice there wasn't much discrepancy between fecal calpro when you're talking moderate to severe versus mild or fulminant, but certainly recognizing that it can be elevated in these situations, as it is in the case example here, is a very important point. It's also provided the additional support many of us needed to have insurance cover this as a test that we order. You'll also notice that we added the row of urgency, which is, of course, a very important symptom for patients with colitis and directly affects their quality of life. And so we felt that this needed to be in the activity index. So moving to the goals of managing ulcerative colitis, we'll just summarize those carefully, but I'd like you to think a little bit more about Ross, and we'll give you a second chance to assess his disease activity. Ross is a 70-year-old man. He was well, and now he's had about 5 stools per day, half of which have blood. He's mildly anemic with elevated inflammatory markers in the blood and stool, and your scope shows that he has a Mayo score of 2. So going back to how we might rate his disease activity, you can score it now and think about where we would put it. All right, good. So we got more of you who agree that he's in the moderate to severe category. Thank you. And for those who aren't sure, that's okay. That's why you're here. We're going to be talking a bit more about it. Some of you might have put him in the mild category because his stool frequency didn't quite meet the moderate to severe category of 6 or more. But if you look back at that table, you'll also appreciate that he does have the elevated CRP and blood in more than half his stools, or at least half his stools. So we throw him into moderate severe for his management. I think that it's not completely wrong to be thinking about whether you might treat him as a mild to moderate patient initially, and then see how he does. But for the sake of this particular case, we were aiming for moderate to severe. And we can certainly talk more about that in the Q&A. Now, when we talk about severity, remember, this is prognosis. And this is for those who have poor prognosis and age less than 40, more extensive disease, and admittedly, I didn't tell you the extent of the disease. Severe endoscopic findings, which would be if the Mayo score was 3 or UCIS greater than or equal to 7. If you required hospitalization for colitis, has an elevated CRP, or low albumin. Remember, low albumin may be a marker of colonic leaking and a more systemically sick patient. So these are the factors you have to think about. Now, why did we separate them the way we have? One of the reasons is because you can have a patient who gets into remission after their disease activity is managed, but you might find out that their prognosis is such that you still need to be thinking carefully about stratifying them to more frequent monitoring or even a different treatment and maintenance phase so that you can keep on top of it in a patient who might have a poorer prognosis. So our man, he was diagnosed at an older age. He's got those elevated inflammatory markers. I didn't tell you about his albumin and some of the other factors. So he's probably in the middle there in terms of what we'd worry about. Remember that elderly onset colitis and Crohn's does exist, and depending on whose analysis you look at, you can see that those patients tend to have a milder disease course in general, but there are always exceptions. So the updated goals of management for UC to tie this learning objective together is make sure that you're getting a careful diagnosis, which includes the extent of disease and confirms histological evidence of chronicity. Separate activity and severity. Think carefully about what you're going to do to induce a response and remission, and now that includes aiming to heal the bowel, which has been incorporated in the guidelines. That doesn't mean everyone can get there, but it means that it's recognized, it's important, and you should try. We know that maintenance therapy might be identified that's in a patient who's otherwise achieved remission with steroids or who otherwise has been treated initially. You should be thinking carefully about how to do that. And new to the guidelines especially was to screen and appropriately treat or refer patients who have anxiety or depression related to IBD, recognizing that this occurs more often in our IBD patients. We want to prevent complications, and if we're doing this in order, hopefully we are, including cancer, hospitalization, infections, and drug-related complications. And in general, it's been recommended to focus on organ-selective therapies before systemic. What does that mean? It means budesonide before prednisone. It means rectal therapies delivered topically before additional escalation of oral therapies. And it may mean some of our therapies that are more gut selective for systemic treatments when you consider other things like extraintestinal manifestations, et cetera. So keep in mind this separation of activity and severity in your management. And with that, I'm going to hand it over to Miguel. I'm sure you're tired of hearing me talk anyway, and let him take us through the next learning objective and a few more teaching points. Miguel?
Great. Well, thank you, David, and thank you for having me tonight. I'm sorry I'm not in Chicago with all of you at DDW, but this is a close second and a nice introduction to COVID and then ulcerative colitis. So my learning objective is really to take you through the data on efficacy, the safety and comparative effective data, as well as routes of administration for clinical trials and treatment in ulcerative colitis. So let's go ahead and get started. So let's start with a case, as David did with his presentation. Let's meet Rachel. Rachel's a 30-year-old female with a history of ulcerative colitis, specifically rectal sigmoiditis. Since the diagnosis 4 years ago, she's been on mesalamine, and more recently, about a year ago, on adalimumab, 40 milligrams subcutaneous every 2 weeks, and azathioprine, and she's on a dose of about 200 milligrams a day. Rachel has required 2 tapers of prednisone since her diagnosis to reduce the number of bowel movements and emergency. She currently has 7 bowel movements a day with blood. Her labs, you can see there, hemoglobin's 12.2, CRP is 22, C. diff is negative. As with a lot of our patients now, and I just will make this editorial comment, when we have a patient with IBD and they're flaring, it's not unreasonable to check for SARS-CoV-2. And I think David already pointed out that many of these patients who have symptoms will be GI symptoms, but she's negative. So what would you do? So this is a little bit of a busy slide, and I think this is probably our only heavy science slide, but these are the novel targets and therapies in ulcerative colitis. And really, without spending too much time on the details, you can see the different classes and different medications there. So let's go on to the next slide. So what are the targeted therapies approved by the FDA for moderate to severe ulcerative colitis? Well, we have 3 anti-TNFs in the top left, and you can see the different names of the trials. And I think most of us are familiar with the adverse events which surround infections. And I think this is something that we look for, especially today in COVID-19. Then there's vedolizumab, alpha-4 beta-7 integrin antagonist, pretty safe. There are some nasopharyngitis, which is not infectious, linked to that. Tofacitinib, which is a JAK inhibitor that has been linked to serious infections, opportunistic infections, specifically herpes zoster. And we do need to check for TB and hepatitis B. And then finally, ustekinumab. This is the anti-L1223, which, like vedolizumab, has a good safety profile, and really nasopharyngitis is the main adverse event. Well, what about induction of remission in moderate to severe ulcerative colitis? And I think this is a nice summary slide to give you some of the inductive agents. So ulcerative colitis failing to respond to 5 aminosalicylates, commonly oral systemic corticosteroids, especially if this is the first time that you're using steroids. Moderate ulcerative colitis, oral budesonide is an MMX. Moderate to severe ulcerative colitis of any extent, oral systemic corticosteroids again. And then the anti-TNFs, Infliximab specifically, and in my practice, I do use Infliximab almost exclusively as combination therapy. And maybe in the discussion at the end, we can talk about when we would use monotherapy. Then vedolizumab or ustekinumab or tofacitinib. And if failed in anti-TNF, then we look at things like vedolizumab or tofacitinib or ustekinumab. And then finally, the induction of remission moderate to severe ulcerative colitis guidelines recommend against the use of monotherapy thiopurines or methotrexate. So we use those primarily in combination with anti-TNF, but not as monotherapy. What about the guidelines recommendations for maintenance of remission for moderate to severe ulcerative colitis? Again, I think by now we all know recommending against systemic steroids is a long-term maintenance remission medication. We do use thiopurines. That is reasonable for maintenance of remission, but I would dare say most of us are not using thiopurines alone for maintenance. We are recommending against the use of methotrexate. How about anti-TNFs? Well, certainly anti-TNFs are very reasonable. Adalimumab, golimumab, or Infliximab for maintenance of remission, including vedolizumab, tofacitinib, and ustekinumab. Anti-DNF therapy overall, I won't spend too much time on these slides. I think you've seen this before. These agents do work on mucosal healing, both for induction and for maintenance across Infliximab, golimumab, and adalimumab. Vedolizumab maintenance and ulcerative colitis through 52 weeks. And again, this is placebo in gray. Kind of the hash green is vedolizumab every 8 weeks, which is our standard starting maintenance dose. And then the solid green is every 4 weeks. And across the bottom, you see clinical remission, durable clinical response, and mucosal healing. with both the every 8-week and the every 4-week vedolizumab statistically superior to placebo. Tofacitinib, similarly, placebo compared to 5 milligrams and then 10 milligrams twice a day, which is our current approved dose for ulcerative colitis. And you can see based on the studies, the clinical remission and mucosal healing, a statistical benefit, especially for the 10 milligram twice a day dose. And then maintenance with ustekinumab, again, clinical remission, clinical response, and clinical endoscopic healing. The 90 milligrams every 12 weeks, which is the hash bars, is something that's used mainly the 12-week dosing in psoriasis, but the solid brown bars, the 90 milligrams every 8 weeks, is what we traditionally use for ulcerative colitis maintenance of remission. So let's go back to Rachel. So just to recap, 30-year-old ulcerative proctosigmoiditis. She's had 4 years of disease, first on mesalamine, now escalates to adalimumab. She has required a couple steroid tapers. Currently, she has 7 bowel movements a day. She does have blood in the stool. Her hemoglobin's 12.2, her CRP is 22, but her infectious workup is negative. So again, what would you do at this point? Which treatment approach would you recommend to Rachel now? All right, so again, blue is the pre-test and green is the post-test. So this is a patient where the majority of you switched your answer, and after the information, you would switch to another biologic. Now, maybe if we have time at the end, we can talk about whether David, you would switch to vedolizumab and ustekinumab, and to Sheila, again, the same question. There's been a drop off, and I don't know, so that's good. But I think this is interesting, and most of you would switch to another biologic, which I think would be quite reasonable. So let's ask a question a different way. What if Rachel was biologic naive? So what if this was the first time she was coming to a biologic therapy for her left-sided ulcerative colitis, failing 5-ASA? So in biologic naive, what's your go-to first-line biologic? All right, so in TNF naive patients, similar to the question that we just asked, in TNF naive patients, there's a better response to tofacitinib or vedolizumab versus those that have failed an anti-TNF. So if your first line is tofa or vedo, that seem to perform better, and you can see the red boxes on both the clinical remission with tofacitinib on the left side and clinical remission with vedolizumab on the right side. You can see again in patients who are bio-naive, there's a better remission rate, and this is something we've seen across trials. So back to the question, what if Rachel was biologic naive? What would you choose first? So again, the post-test is the green, so we've had a large switch here. This is kind of interesting. So in biologic naive, I think prior to the test, most of you were pulling for an anti-TNF. After the information, most of you actually switched your answer to vedolizumab. There was an uptick also in the JAK inhibitor tofacitinib. So very interesting, and maybe if we have time at the end, we can discuss this as well. So I think you've seen these data before. These are the Infliximab plus Azathioprine versus monotherapy. And again, pretty much this is showing that combination treatment with Infliximab is superior to placebo and is numerically higher in benefit in mucosal healing, but is statistically better in terms of clinical remission. So the same combination approach we see in Crohn's, we're seeing the benefit in UC with Infliximab. Vedolizumab versus adalimumab, this is the varsity study. I think you've seen this before, but just to ground you in the study, this was a double-blind, double-dummy, multi-center active control trial in moderate to severely ulcerative colitis patients. The red bars are adalimumab, the green bars are vedolizumab. The primary endpoint was clinical remission at 52 weeks. So you can see for the overall primary endpoint, there was a statistical benefit of vedolizumab compared to adalimumab. And you can see if there was no prior anti-TNF, you see the separation of the bars. If there had been a prior anti-TNF, numerically higher for vedolizumab, but the bars are closer. So interesting study, first compared to effective head-to-head. Well, this is something that a couple years ago, Ben Click and I put together a safety pyramid. And I should say that when we're deciding on treatment, we quite often discuss efficacy, but also for our patients and certainly for us as physicians and healthcare providers, we also look at safety. I should say that this is not a prospective study. This is more of a visual systemic review that we perform, looking at the safety across multiple trials, post-marketing data as well. And so we put this safety pyramid, if you will, where the top of the pyramid is what we consider the safest, and the safety of vedolizumab and ustekinumab we would put at the top. Anti-TNF monotherapy, then thiopurines or tofacitinib, and then combination anti-TNFs and thiopurines. It's very important to see at the very, very bottom are steroids, and I think that that's something that's important for us to recognize. And then the box on the right side, inadequate treatment is an adverse event into itself. So even though we put anti-TNF with a thiopurine at the bottom of the safety pyramid, if we think that that is the best treatment for the patient to induce remission, we should use it. However, in the totality of data, ustekinumab and vedolizumab monotherapy appear to be the safest. So when we individualize treatment, I think there are several factors we need to take into account. Age over 65, we probably use something like ustekinumab or vedolizumab monotherapy. For patients, though, infliximab is probably the agent we use the most. Cyclosporin is also something we can use in certain centers, like David in Chicago will still use cyclosporin. And then induction, but now followed by azathioprine or vedolizumab has been interesting data with cyclosporin. If they've had a significant cancer risk or lymphoma, while we can use anti-TNFs and thiopurines, we're more likely to use ustekinumab or vedolizumab. In pregnancy, really the monoclonal antibodies are all, in my estimation, safe in pregnancy, and we have pretty good data on that. Steroid responsive mild to moderate disease, we list thiopurines here. That's rare for us to use as monotherapy today. And it's important to look at extraintestinal manifestations, especially if there's severe arthritis, tofacitinib, ustekinumab, and anti-TNFs. And then finally, for those that have failed anti-TNF therapy, tofacitinib, ustekinumab, and vedolizumab would be quite reasonable in ulcerative colitis.
All right.
Thank you. And I'll turn it back over to you, David.
Miguel, thank you very much. It was a terrific overview. I just want to remind the audience that you can put your questions in, and there are some wonderful ones that have come in, and I promise you we're going to address them all. There's some people who want to know a bit more about the data supporting COVID management related to therapies, and I agree with their questions very much. And then Miguel, there are a few people who are asking us about therapeutic drug monitoring prior to drug dosing or changing therapies, as well as choices of treatments for older patients, and we'll get to all of those. So I just wanted to tee you up so you can be thinking about them. So now as we move to learning objective 3, it's really my pleasure to welcome Sushila Dalal, who's one of my partners. And Sushila is just outstanding with her patient population and also one of our physician scientists at the University of Chicago. But today she told me she spent all day doing virtual visits. She had 17 IBD patients that she did videos with. And despite that, she's going to spend a little time with all of us, still on her computer, but also it lends itself to her credibility and her experience in teaching us a bit more about how to talk to our patients. So Sheila, take it away.
All right, thanks so much. So in learning objective 3, we're going to talk a little bit about shared decision making. As we just heard a lot about efficacy, we heard a little bit about safety. What we didn't hear about are any biomarkers that tell us which one we should choose and how we should decide about all these medications. So we're going to get at that a little bit with how we come to decisions and how we combine our evidence with our patients' preferences. So we're going to start with a case. In this clinical case, we're going to meet Joey. Joey's a 32-year-old man with extensive ulcerative colitis. Since diagnosis, he's been in remission on mesalamine, 4.8 grams daily, but he recently developed worsening symptoms. Now he has 8 loose, urgent bowel movements a day with blood. He's currently on prednisone. He had a flexible sigmoidoscopy, which showed that he has moderately active inflammation. His labs show that he's mildly anemic with a hemoglobin of 11.2. His CRP is elevated, and he's negative for C. diff as well as SARS-CoV-2. So Joey needs a new medication. How would you approach this conversation and decision with him? So we can see that most people will discuss with Joey. Okay, and so let's talk a little bit more about how we can come together for a decision. So shared decision making, what do our patients say about it? When you ask patients, do you feel that your clinician engages you in treatment decisions, and do you discuss your treatment regimen preference, the history of your disease, and the severity? Some patients will tell you, yes, the doctor I have now is very engaged with my symptoms, with treatment plans, and anything I want to discuss about my IBD. And we know that when patients feel like that, they often have better adherence to therapy and quality of life outcomes, and often feel that they have a more trusting relationship with their provider. However, some patients tell us that my doctor tells me what the treatment is, and I just do what she tells me. I'd like to feel that we make decisions together, but she never seems to have time for that. So some patients are telling us that they don't really feel like they're being heard, and that their doctor is in a rush and is not able to sort of engage with them. So there's a spectrum of patient to provider communication. And along that spectrum, on one end, we have the paternalistic or maternalistic provider who is telling the patient what the best thing to do is and informing them. And on the other side, we sort of have the patient-dominated consumerist approach. And there's a sweet spot in the middle where we have a balance of what the best evidence is and the provider's preferences and the patient's values and concerns. So the ways the provider can sort of move the needle over to the center is to be present and listen to learn and really listen to find out, well, what is important to the patient? Do they value efficacy the most and they're willing to undertake some risk, or is risk really what's going to drive their decision? And try to tease out how they're going to come to a decision. Asking open-ended questions to try to elicit those patient preferences and identify with the patient what their goals. I think it's also important to identify to the patient what your goals as a provider are. On the other side, how can you move the other way when you're sort of in more of a patient-dominated place is, again, identify the patient goals and proactively manage their expectations. Tell them, okay, we're going to try this therapy for this amount of time, and then we're going to test how it's working by doing a fecal calprotectin or by doing a scope and sort of manage what's going to happen next so that they can anticipate it and participate in it with you. So how do we incorporate patient preferences? So it's important that our patients sort of understand about their treatments. What's important to them may be the efficacy and maybe the safety, but there's also things that are practical to them. Is it an IV infusion? Is it an injection? Is it oral? So they need to know that, that Infliximab and Vitalizumab are infusions every 8 weeks, and that adalimumab, golimumab, ustekinumab are injections, and tofacitinib is oral. We know that this matters for the patient, whether they travel, whether they're able to take time off from work, whether they think that they can do the injection for themselves at home. So these are some important things to bring into the conversation so the patient can let you know their preferences. So what strategies can we employ to empower our patients to communicate about their preferences? We can focus on the present moment, focus on that clinic visit. It's difficult in a busy day, but you're sort of taking that moment to listen to what they say and what they tell you, because maybe it's not what you think they'll say. Maybe what you think is going to be most important to them, or what they will agree to is not the case. Maybe you think that patient would never agree to something like a suppository or enema for their proctitis, but their preference is really that they just need to get well, and they're willing to do that. So you really need to ask them and see what they actually think. Ask situational questions that help the patients open up to additional considerations. Ask them, well, if this happens, what would you consider? So that they can kind of think more broadly about things that they haven't considered before. Provide the information. It's a shared decision. In order to make that shared decision, you really need to provide the patient with the best evidence, so that they have the materials to make a decision. I think there is some tendency for patients to say, well, I'm not sure. I don't know about these medicines. You're the doctor. You decide for me. But if you give them the tools to understand why we would choose these medications and how we think they work and why we would use them, then they can better participate in the decision with you. Create a shared set of goals and check them off at each appointment. So, set the goals with them. I tell them, of course, we want you to feel better, and clinical remission, of course, is of the utmost importance, but we also need to make sure that your colon heals, and these are the ways we're going to check on that, and these are the time frames we're going to do it. Because I think a lot of times they're worried, I'm going to take this medicine and undertake these risks, but how are you going to know if it's doing anything, and how are we going to know if I made the right decision? So it's important to let them know that we're going to keep reevaluating our decision, and we can adjust if need be. Okay, so there's also some digital tools we can use to empower our patients and help them participate with us. There's an online decision aid, IBD and Me, which actually can generate a personalized therapy preference. It goes through the medications, it goes through what they are, what the risks and benefits are, and then it actually has an interactive feature where the patients could actually generate a report, which can be helpful for patients to go through to discuss with their physicians rather. GI symptom trackers can also be really helpful. These are just a handful of them are listed here, but this really helps the patient sort of recall what they've been experiencing, so they can bring that to the physician and make that part of the decision-making process. And they can perhaps better tell you their viewpoint and what they've been experiencing. So here's some examples of effective and ineffective communication. Some ideas of effective communication. Let's discuss the risks and benefits of the options to find out what's best for you. Kind of recognizing that it's a multifaceted decision that you're making. Making sure that you're asking what questions the patient has and leaving time for the patient to ask questions, because maybe they've got questions you haven't even thought of, maybe a factor in their decision. Validating their question, letting them know it's a good question, and many people are in the same boat with that. And also giving them time. It's pretty hard to be put on the spot during a 40-minute appointment to decide, okay, what therapy are you going to choose? So often telling them, feel free to call me back or send a message if you have more questions as you think this over. A lot of times they'll want to discuss it with a partner or family member or friend and think of more questions later. Ineffective communication, it feels rushed. It feels as if the patient didn't really have a chance to process things and ask the questions, and as if the provider wasn't paying attention to them. The patient doesn't feel as if his or her concerns were answered. And also on the patient's end, if the patient doesn't report his or her symptoms or mention the questions they have, then the physician really isn't able to take into account their values and opinions as well either. With that kind of wraps up this area. We'll go back to you, David.
Thank you so much, Sushila. Now, I recognize that some of that for busy clinicians makes sense, but there are some details that came out in some thoughtful questions that people have posted, so we'll get to those. And I want to thank you for going over all that with us. So let me just summarize what we call the SMART goals, and then we're going to dive into this wonderful bevy of questions, and we'll be taking more of those for the next 20 minutes or so. So first of all, choose appropriate therapies during the COVID-19 pandemic, recognizing that this is a fast-moving area and there'll be many updates, I suspect. Differentiate activity from severity in colitis. Activity, how sick your patient is now. Severity, their prognosis. When you're assessing them, when you're choosing therapies, and when you assess them in future monitoring strategies. Choose therapy based on activity, severity, extent of inflammation, and those prognostic factors. Include oral, topical rectal therapies, systemic therapies, and obviously surgery, which we didn't get into yet, but we will during some of our questions now. And think carefully about what we know regarding sequencing and comparative effectiveness, although admittedly, there's a lot more we can learn. And then lastly, make sure you're prompting patients with open-ended questions so that you can encourage a shared decision-making approach. And we'll talk about some strategies to do that effectively, but also to take into consideration the real-world phenomenon that payers drive some of this. So Miguel and Sushila, I'm happy to tell you that there are over 700 people logged into this program right now, many more than would have been there for the free breakfast at DDW. So. And we're going to go back to a few things. I'll start with the questions we have about COVID-19. I think they're very thoughtful questions and they're practical ones. The first one is that someone wanted to be reassured that we think patients with IBD are not specifically at increased risk for getting SARS-CoV-2. So Miguel, let me ask you how confident you are in that, and maybe you can reflect on the IO-IBD consensus that you participated in as well.
Yeah, so I think, one of the, I realized Sushila did virtual visits or telemedicine all day and probably didn't get through a visit without COVID-19 coming up with a question. And I think it is reassuring. So what we've seen from the SECURE registry, from our discussions and analysis through the IO-IBD, is that the percentages of patients presenting with COVID who have IBD are fairly low, and certainly much lower. I was even looking at some data earlier today, much lower than hypertension, diabetes, obesity, pulmonary diseases. So I think it's early days, and to say that this has really been something we've been analyzing in 2020, to say we know everything isn't true. But at the same time, I am reassured by the early data. I think if there was an uptick, we should have seen it by now. Also nice to see that it's not overrepresented in our patients who are on immunotherapies of any type, which is also reassuring.
Yeah, I would add to this, there's a distinction between saying that someone with Crohn's or UC in and of themselves are at increased risk versus incorporating the possibility that our patients on immunotherapies might be at increased risk. It's an important distinction, but it's something we should keep in mind. In addition, there are data from the original SARS epidemic in 2002 through 2003 that suggested that those who were on immune therapies, not just with IBD, but other conditions, did not have an increased risk. There's the case series from NYU of immune-mediated diseases that's in press right now in the New England Journal of Medicine, where they did not see anything specific other than age and some of the other comorbidities we've already seen, and possibly steroids as well. So you're right in asking this question, but in the meantime, we don't think that our patients in and of themselves having IBD puts them at increased risk for this particular infection. On the other hand, we certainly know that our patients on these therapies may have some risks. So Miguel or Sushila, the next question from one of our participants tonight is, what data do we actually have that TNF inhibitors may put people at increased risk, such that we would even suggest we should hold them? And then another person, or maybe the same one, said, given the half-lives of these drugs, what are we actually doing by telling them not to take them for a couple of weeks? Who wants to tackle that?
Sushila, do you want to answer? I'm happy to.
You can go ahead. Sure.
So I think, these are excellent questions. To start with the anti-TNF question first, and then I would probably broaden it to medicines. We have not, based on the data such to date, have seen increased rates of infection with COVID-19 in patients on anti-TNFs, or for that matter, any of the biologics. What we have seen or are concerned about is that higher levels or higher doses of steroids may actually be associated with worse outcomes in COVID-19. So if I were to separate it into, do the medicines predispose to COVID-19? We haven't seen that for our medicines. When the patient is infected with COVID-19, we try to avoid or limit the medicines that may be associated with our worse outcomes in viruses. So over 20 milligrams of prednisone or equivalent, the tofacitinib, the thiopurines. As far as holding the medicines, you're right, or whoever was asking the question's correct. There is a washout period with thiopurines and others. Nonetheless, I think it behooves us in the sick patient in the ICU, for those that have seen those patients, we're going to practically stop their immunotherapy. If it's an IV or a subcutaneous dose, and they're due for that, missing that or delaying that dose for a couple weeks is fine. So I think it really comes down to the daily therapies of thiopurines, tofacitinib, steroids, where we really would want to withhold those. Understand there's a washout of thiopurine, short half-life with tofacitinib, but we'd still want to hold those medicines.
Yeah. I would encourage folks to go to the covidibd.org website and look at some of the data. Admittedly, they haven't done a multivariate regression to control for different variables, but you'll see that there hasn't been a clear spike. And maybe the numbers of patients, thankfully, who've been in the ICU or who have died are so small that we can't see that at this time. But the person who asked a question about cytokine storm being prevented by our anti-cytokine therapies is certainly a very reasonable thing to think about. We do know that there are trials going on now with anti-IL-6, anti-TNF, and with JAK inhibition in COVID. So there may be benefits here, but in the absence of that, it seems practical that at least in the infectious phase, not dosing someone with the drug is practical. And this is just pragmatic until we know more. Certainly understand that. Okay, another question. Sushila, should we be checking for SARS-CoV-2 in everyone who presents with a relapse of their IBD?
I think that at this point in the pandemic, it's reasonable to do so, given that the symptoms of a relapse would often overlap with possible symptoms of COVID-19.
So certainly if they had otherwise been well and you don't have a otherwise identified reason, we certainly also know some patients who have just stopped all their therapies or didn't go to their infusions where it might be more obvious, but I think that's practical. Miguel, is the Cleveland Clinic offering serologic antibody testing?
So it is that, yeah, the whole testing is a loaded question that we debate, and probably an hour doesn't go by in days when we talk about this. So to be clear on the testing, there's the nasal swab, or what will be saliva RNA testing, which is to show is there active infection. And then to David's point, the serologic testing, IgM, IgGs. And then the debate or the dilemma is that there are some questions about the sensitivity and specificity of the serologic testing. To answer your question right now, while it's offered at Cleveland Clinic, we're not routinely doing this today. Everything changes each week. There's an interest from the healthcare standpoint and provider standpoint of having a good serologic test to let us know if we're somehow protected. The other part of this, as you might get to, is even if you have serologic IgG, we think that's protective, but we don't know, and there's some question about different strains, whether you could get a reinfection. So a lot of unanswered questions. We're not routinely testing serologic testing today.
The primate animal research suggests that IgG is protective, and we obviously want to know that in humans, but that seems reassuring. The other thing to keep in mind is there's actually no serologic test that's FDA approved. There are several that are being reviewed. So there's many out there, but they're not all the same, unfortunately, so apologies. I'll just ask two more questions about that, then we're going to move on to the other thoughtful questions that the participants have sent us. One is specifically about PPE for colonoscopy. When a patient who you do not suspect has COVID-19, Are you using the same PPE at the Cleveland Clinic, or Sushila, you can talk about the University of Chicago? And are you pre-testing everyone, whether you suspect it or not, before they have scopes?
So probably these alone have occupied 30 hours of our day the last 3 days. So PPE, to start with that, our guidance at Cleveland Clinic is in the absence of testing in an asymptomatic patient, we are using N95s, which is the key component of the PPE, in all of our upper endoscopies and our colonoscopies. That is what we're doing today, and that's still the guidance. We do use single-use all-day N95s, and I think most sites are doing that, and we can get into the details if you would like. As far as testing before endoscopy, the answer is no. If the endoscopies are being done in a endoscopy-contained unit, so an ambulatory endoscopy center or an only endoscopy center in the hospital, we are not testing. However, if the endoscopies are commingled with patients who are undergoing surgeries, ambulatory surgery center, those patients are being tested. Not because we're necessarily worried about a test positive patient who's asymptomatic having a complication with a scope, but it more has to do with the commingling of patients in these units. And there's a lot more behind it, but I'm giving you the Cleveland Clinic answer, and I'm curious to hear what you're doing in Chicago.
Sushila, do you want to tackle it, or do you want me to take it?
You can take it.
Yeah, so similar to you in PPE use, we do have extended use N95s. The policy is if you take it off, though, you're done with that one for the day. We also have ultraviolet recirculation cleaning of the N95s. Although we haven't needed to do that, it's being done to preserve what we have. We are testing everyone at the current time. They have to come down, though, the day before. We do have point of care tests, but they're in limited supply and use predominantly in the ED. So we are testing everyone at the current time with the idea that, although it doesn't show PPE, because we're using full PPE right now, if we did find someone was positive, we would do their scope in a negative pressure bronch room or in the OR where there's negative pressure rooms rather than in one of our endoscopy rooms. This is still evolving, and I would refer folks to the multi-society guidelines on endoscopy that have come out to read more about this. And the IOIBD website has the endoscopy task force commenting on some of these things.
And the only other thing I'll add to what David said is I think it also has to do, and you probably can't turn on the news without seeing this, the accessibility of testing too. So as we ramp up our endoscopy volumes and get up to high volumes, we will have patients who come in not tested even into centers that we want to test. And I think we just have to use good practical guidance. If they're asymptomatic, they don't have a fever, probably not needing to cancel those patients, but that's a personal opinion.
All right, and the last question about COVID for now, although more floating in, is do we think that COVID-19, when it causes GI symptoms, raises calprotectin? I think that's an interesting question. Our GI pathologist, John Hart, who's just a wonderful expert, is part of an international group of GI pathologists, and they've described that patients who've had biopsies of their intestinal tract during this pandemic have not had histological abnormalities, sort of akin to cholera, which also doesn't. So you might predict, given that calpro comes from activated macrophages and neutrophils, that a pure COVID-19 associated GI symptom of diarrhea would not elevate the calpro. So if you do have an elevated calpro, look for the IBD relapse or a different infection. At least that's the thought. And I think there needs to be more done here.
Yeah, and the only thing I'd add, so I agree with David, the only thing I'd add to that is people probably know that the ACE receptor is what likely the COVID attaches to, and this is found through the GI tract, the enterocytes. The only exception to that, and we did have a couple of these patients, not IBD, because of the microthromboembolic potential for COVID patients, we are seeing some ischemic colitis. Now that's different than what you're referring to with just pure diarrhea and COVID, but keep that in mind. If you have a new onset bloody diarrhea and somebody's sick, it could be an ischemic event.
All right, I'm going to shift gears now. Here's a tangential but important question related to COVID, and it'll be a good segue. So Sheila, how do you bill for telehealth? Can you just update the audience on what the federal government's allowing and how we're doing it?
Yeah, as of now, for video visits, we are able to bill as an in-person visit, is my understanding. So for a video visit, whether, in our institution, we've done it through Zoom, or we've done it through Doximity video app, we're able to bill as if in person. So they've expanded that for COVID-19. Telephone visits, however, are not reimbursed like an in-person visit.
Although they're working on that, right? So there's been conversations that some telephone calls might get billed at a low level return, but there's still conversations about whether that'll work state by state. Great. There's lots of comments that I'll share with Sushila and Miguel that this was a great program. Thank you from Brazil. Actually, they said goodbye, adios de Brazil. Someone has no audio, but I suspect that maybe your own computer, sorry, home, and you can't hear me saying that. All right, let's move on. Miguel, there were a number of questions regarding your patient who was on adalimumab. She had had 4 years of colitis. Oh, and we have someone from New Zealand who just said thank you. That's very nice. But Miguel, what about checking an adalimumab level or looking for anti-drug antibodies before making a decision about staying in class or moving to a different mechanism? Can you comment on that?
Yeah, I think that's a very reasonable question. I mean, she was on combination with azathioprine, and you could also ask the question, does she really need combination if she's done well for so long? But I think if this is a patient that you had not been proactively testing to begin with and had been on adalimumab and doing well, and you could not find another reason that she's flaring, I think it would be very reasonable to check a level. And usually with adalimumab, depending on the lab, I try to target at least 10. So if her level was low, you could either re-induce with a full 160/80, or you could go to 40 milligrams every week. That would have been a very reasonable answer. And I think whoever's asking that, that's probably what I would have done in practice. And then depending on what we found, high antibodies, secondary loss of response had done well for 4 years. You could certainly argue to stay within class and switch to Infliximab or golimumab. If it is a patient who's had levels of adalimumab over 10, or what we would consider adequate levels, no antibodies, a little bit strange that she's lost response after 4 years, and then I'd really want to look for something else. But if that were truly a failure of drug, I would switch out of class to either vedolizumab, ustekinumab, or tofacitinib.
Yeah, I think staying with the mechanism that was working when you know that it was an anti-drug antibody issue is always better with anti-TNF than necessarily making that swap. Hello from Riyadh, Saudi Arabia. Hello from Paoli, Pennsylvania. Thanks for joining us.
Paoli.
Yeah, are they next door to you?
That's in the eastern side of Pennsylvania, but it's interesting it went from Riyadh to Paoli.
I got it. Okay, so Sushila, there's lots of questions here about the practical reality. You have this long, engaged conversation about safety and convenience and tolerability and effectiveness and Plan B, and then the patient and your team find out that the payer wants them to only be on sulfasalazine, which literally is one of the points that someone made here. It may not be that extreme, but certainly, how do you handle that? And what has been your experience with, for example, getting Veto as a first-line drug before having to go through anti-TNF in your practice?
Yeah, I think, It's a very good question, and unfortunately a reality of our practices. I think that I do bring it up with patients in our conversation when we're discussing the therapies. I say, we've decided upon this. We're going to request it, and I will advocate for you for that. However, this may happen. It may be rejected in favor of another medication. I've been successful in being able to get vedolizumab as a first-line agent. I think oftentimes when a medication is denied, I find that a peer-to-peer appeal or a letter of appeal is often successful, especially with using the particulars of the patient's case. Sometimes, whether it's true or not, the insurance company comes back and tells you, oh, we didn't have those details before. Okay, we'll give you the medication you requested. So sometimes it's as simple as they needed more information. Sometimes just pointing out the data that you have. I mean, certainly for vedolizumab as a first-line agent, you can cite Varsity, you can cite the literature and include copies of the literature. So I think taking that extra step for appeal is often helpful in that state. Sometimes it doesn't work. Sometimes that is the case. And I have another conversation with the patient and I said, look, we weren't really sure. You and I were between these therapies. We're going to try this. And I tell them, but we're going to check back with an objective marker to see if it's working or not. And if it's not, then we have another opportunity to switch. So we say, okay, it's okay to try it. This is an FDA-approved therapy for it. It's indicated, but we're going to set goalposts and make sure it's working. And if not, we can adjust accordingly.
Yeah. I mean, I've gotten to the point now where I tell patients that we have plan A and plan B, and we actually go through it before they leave, so that if they get that call that says your company denied this, your insurance company, then we will either appeal, or at least they know that we talked about plan B and that I'm supportive of that option as well. So that's the practical reality of where we all live right now in the world of IBD and in payers. So that's very helpful information. Miguel, can you help us with treat to target in ulcerative colitis? Let's take, you just started a patient on tofacitinib or Infliximab, take your pick, but what do you do to assess whether the drug is working? There's some questions here about Calprotectin, about when you might scope. Tell us how you do this.
Yeah, so first of all, I want to shout out to everybody tweeting. It's exciting to see the number of tweets, as David said, from all over the world. So thank you for that. I think that's one of the nice things with our virtual programs now. Not only they're
Washington, D.C. These are the people sending us questions. I haven't been able to look at Twitter quite
yet. It's like you said, Australia. I don't know. The time zones must be crazy. So although I guess New Zealand and Australia.
You know what? You're worth staying up for.
All right, so how do we do treat to target and assess response? I mean, I think obviously when I'm with a patient starting a new therapy, biologic or small molecule tofacitinib, I think the first thing we tell them is that we want them to feel better and we want them off of steroids. And I would like to see some improvement in symptoms, especially if you use what we call PRO2, patient-reported outcome, an improvement in blood and diarrhea by a month. Not perfect, but they're improving and we're able to begin to taper their steroids. For those that use Calprotectin, the thing that I would like to do is have a Calprotectin that is paired with a colonoscopy, meaning a very high Calprotectin with a very bad looking colon. There's a nice match there. You could use CRP if it's elevated. I don't use ESR as much anymore, but I think those are the objective measures. So what I do is I tell them at 2 weeks, I want to have a phone call or now virtual visit. We want to check in and see how you do. Obviously, if they're getting worse, we want to know before then. By a month, I really want to see some improvement. And usually by 4 to 8 weeks, I'm checking either a serologic marker, CRP, or a Calprotectin. So within those first 2 months, I normally in my patients will rescope them at 6 months if they seem to be responding. If they're not responding, I'm very worried about something that would require surgery. I'll sometimes do a flex sig at 3 months. But my rule of thumb is clinical symptoms within the first month, a week, 2 week check-in, objective marker measure within the first 1 to 2 months fecal calpro CRP, and then at least an endoscopic reevaluation can be a flexible sigmoidoscopy at 6 months, sooner if they're not having the response I want, or if I'm worried about a co-infection like CMV.
My approach is very similar to yours, Miguel. I've gotten in the habit now with both Crohn's and UC of arranging for the patient to have a 6-week something, usually Calpro or CRP, but something to assess where we are. I tell them that they shouldn't get worse when we start a new therapy, but they may not be perfect immediately. And that gives them a target so that we know when we're going to reassess them, and we plan for a follow-up visit depending on their risks otherwise. A couple more regarding how to get credit, etc. The CME Outfitters crew will be emailing everyone. If you gave an email address when you registered, then you will get an email that gives you the evaluation opportunity and how you can get your CME and CE credit. So I want to make sure that everyone knows that. We've got a few more minutes and then I do have to wrap. Sushila, there's a pharmacist from Hawaii who says how important it is to document properly so that prior authorizations meet.
Absolutely. I think that's a really great point. It is really important to make sure that you've included the clinical symptoms, you've put in the medical history. Sometimes, adding in that diagnosis of psoriasis or arthritis can be helpful as well. And also your assessment of the disease severity in your assessment is really important. I like to say outright that I am planning to start X drug for moderate to severely active, ulcerative colitis that's failed to respond to other medicines. I put it right in my assessment, and then I say they've tried this and that. I sort of list everything that they've been on right in my assessment and plan to kind of head off any questions or that, well, have they tried and failed this? What's their disease severity? I try to put all of that information in my assessment and plan.
And actually, one thing, David, I want to add to what Sheila said, and I think the pharmacy documentation is important also when we escalate therapies, because there were a couple tweets about people who are on every 8-week vedolizumab or every 8-week therapy or every 2-week injections, and with vedolizumab going from 8 weeks to 4 weeks. And even though that's not technically in the label, we are getting enough approval for dose escalation. So I completely agree with what Sushila said.
Sushila, I didn't mention this, but she also leads one of our transition clinics for teenagers as they move to adult practices. And there are some questions tonight on the appropriate treatment for teens. And at the opposite end of the spectrum, we have questions about, would you choose different therapies if the patient is elderly or older, like the patient example I shared? So I'll let each of you comment briefly on those, and then we're going to wrap.
Yeah, I think that that can be a challenge for teenage patients because there is a difference in what medications are FDA approved for the pediatric population under 18 and those over 18. However, there is data for use of some of the medications such as vedolizumab or ustekinumab that are not approved. So if other therapies have not been successful, there is data to refer to in trying to gain approval for those medications.
Very good. Do you want to add about older patients?
So the other end of the spectrum, same thing. I think the only difference with the older patients is that I'm more likely to use monotherapy. Vedolizumab probably would be my first choice in somebody with ulcerative colitis. Ustekinumab would probably be a second choice. But to be fair, if it's somebody very, very sick, elderly, first of all, we really have to talk about surgery, but I would not hesitate using an anti-TNF, but monotherapy vedo would be my first choice. And from a payer standpoint, fortunately, we've been pretty successful, not just with the anti-TNFs, but vedo and to some degree the other agents as well.
I agree completely. I would say that sometimes you do need to use these other treatments as well. You just have to be monitoring carefully and vaccinate and all the other things that we recommend. So that sounds like a great topic for the next one of these that we're going to. I want to thank all the people from clearly all over the world who've joined us tonight to learn, or maybe it's morning where you are, learn about colitis management, to talk a little bit about some of the challenges we're facing in the era of COVID-19. I want to especially thank my two faculty colleagues and friends, Miguel Reguero and Sushila Dalal. And of course, thanks CME Outfitters for setting this all up, and the flawless technology. I have 4 different windows open on my computer, and it seemed to go perfectly. Go to the cmeoutfitters.com website if you want to get other resources, including some of those patient assistance website tools. And I also want to make sure that you know that you should stay tuned, follow them on Twitter, follow us, and good luck. And please, everyone, stay safe as we get through this unprecedented time in all of our lives. Good night.
Thank you, David. Good night.
Thank you. Good night.